Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Make sure you block time in your schedule for our 6th Risk Management Roundtable on Thursday, June 18th at 5 p.m. Eastern Time, and our 4th Telehealth Community Chat on Monday, June 8th at 5 p.m. Eastern Time. I also want to remind you of the many resources that can be found on our COVID-19 resources page, and to let you know that we've started posting past episodes of our virtual webinar series online. I've included links to both of these pages on our important information slide, which is in front of you. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. 3 of our advocates are with us today, Drs. Eric Harris, Julie Jacobs, and Liesl Bryant. In the interest of time, we've placed their bios on a slide. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other risk management credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Please remember to submit your CE certificates with your policy renewal. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters. Liesl?
Great, thanks, Jana. We are all glad to be back with you today. And we're gonna dive right in, because as always, time is short. We've been getting a lot of questions still about face-to-face, returning to face-to-face work with folks. And so we're gonna go into that. I know we've talked some about that in prior webinars. And as Jana said, there's some documents listed in the chat so that you can link into some of that they're going to talk about. So we're not going to go through everything we did before, but we're going to sort of go a little bit more in depth today, at least in the beginning, and then we'll get to your specific questions as well. So we'll start with this, and Julie, I'm gonna direct this to you first. Okay. There have been some checklists that have come out for psychologists to consider before transitioning back to the office. The CDC suggestions, however, are not very clear. So what are the factors that we as clinicians should absolutely consider and do if we are in a county where there's high COVID rates, for instance? So things like, if you can speak to things like, should we be taking temperature? Should we be wearing masks, hand hygiene, 6 feet of distance, those kinds of things. Julie?
Yeah, great. Thank you. I appreciate that. It's a good question. And, there's a lot of confusion and there's a lot of guidance out there, which can be helpful, but it can also muddy the waters sometimes. So I think one thing that we need to all remember is that when we look at these checklists and look at the guidelines, not all of these things are going to apply to every practice. And so if you have a small mental health practice with 1 person and you're just seeing, individual therapy clients in an office that you rent, what you're expected to do is going to be different than, say, a hospital or a clinic that owns the building that they're in that sees a large volume of clients. So I'm going to take Eric's analogy and sort of compare it to HIPAA compliance, right? When you have HIPAA compliance concerns, it's scalable. So depending on the size and scale of your practice, there are different things that you might need to implement. So I think similar things will apply to some of the guidance regarding the coronavirus and COVID-19. Specifically, one thing that you didn't actually mention, Liesl, but I'm going to start with, because I think it's the one that trips people up a lot, is the idea of ventilation in the buildings that we're in. If you're going to be doing in-person services, the CDC is pretty clear that you want to try to do something to improve ventilation systems to the extent that you can. Now, again, if you're renting an office in a building, you probably don't have the ability to do that. So you could certainly inquire with the building owner or the landlord as to what they intend to do. There are adjustments that can be made to an HVAC system that could improve ventilation. So that would be something you might do if you are renting and not actually owning the space or able to control that yourself. And certainly if you do have a large building and you have control of that, you want to look and talk to the HVAC folks and see what can be done to improve ventilation. But there are also things that might be done on a smaller scale. There are portable HEPA filters that you can actually put into your office that, while not an ideal solution, is certainly better than nothing, especially if you have no windows in your office. I mean, being able to open a window is going to be really helpful. And if you don't have that option, then maybe look at some of the portable filters or some of those other things that might be out there and available. Taking temperature is something you talked about. There's a bit of controversy about this too. There's a lot of psychologists who don't feel comfortable screening people at that level of sort of at a medical level like that, to purchase the thermometer and be taking the temperature on their own. They feel like it's a little outside their scope and they're not super comfortable with that. Now, if you're comfortable with it and you have the equipment, that's certainly a protocol you can put in place, and you can establish a baseline temperature at which you would ask people to not present or to go home. Or you could ask people to screen themselves. You could have a short screening questionnaire that just lists certain symptoms, and the temperature being one of them. And you could check in with your clients at the beginning of the day that they're supposed to show up and ask, what's your temperature this morning? Do you have any of these symptoms? Have you been exposed? And create some sort of small screening process that you can engage in that you feel comfortable with. So temperature taking, I think, can be important, but whether it's you who do it or if the client does it themselves and reports back to you, that might have the same impact. And again, all of that is said knowing that people can certainly be asymptomatic and shedding the virus. So it's an imperfect solution at best. Masks, hand hygiene, 6-foot distance, things like that are pretty baseline, right? I mean, at this point, you certainly need to know what protocols are in place and required in your location. So certain states or certain cities or counties may require face coverings, even indoors. So you need to know, it's incumbent on all of us to stay on top of this, which is tricky, I know. I check every single day the Colorado public health orders and executive orders, and they weren't up to date today. So there's been a couple that weren't even on there that I had to hunt around for. So easier said than done, but it is important for you to know. If your locality requires face masks indoors, well, there's your answer, right? You better do it. Whereas if it's optional or a suggestion, then you as the practice owner or as the provider are going to make that decision and make that determination. I don't think there's anyone who could say with a straight face, we shouldn't have hand washing or hand sanitizing in our offices, okay? That's a bare minimum. The 6-foot distance is a pretty solid recommendation, especially if you're going to be indoors. So we should think about these as minimums. And these are precautions that everyone seems to be using and should be engaging in when they're engaging in person, face-to-face services. I've also seen people ask about, if you're wearing a mask, if I'm requiring masks, do I need to require that mask throughout the entire session? Or is that just walking in hallways or waiting rooms or places where they might run into other people? And again, this depends on a lot of factors. Is your office large enough to actually be more than 6 feet away from each other with a window open or with adequate ventilation to the extent where you would feel comfortable not having those face coverings? The CDC seems to think and seems to be suggesting at this point that face coverings are important if you're going to be indoors for an extended period of time with another person. So face coverings certainly include masks. If you can't do that for some reason, there are face shields. These are an imperfect solution. Air can still get through them, but they would protect from droplets that were actually projected onto your face. It's not a perfect solution. It's an option if you feel like you can't use a face mask for some reason. There's also masks that have clearer insets now for people who are hard of hearing or who just might feel like they really need to see a little more of the person's face in order to be effective doing the work that they're doing. And then kids, people ask about working with kids in masks, and that's something to think about. In my states, they're very clear that masks are not suggested for young children and that they're only a suggestion but not a recommendation for 12 and under. They encourage parents to have kids wearing masks, but they don't require it. It might be harder to keep the mask on the kid. They might be more willing to take it off. So, look at your local guidance, and at a minimum, I would suggest the provider wear a mask if they're indoors and if they're resuming this in-person services, especially if you can't keep social distance or can't have adequate ventilation. So those are some of the things that I think are sort of a minimum to at least consider very seriously. And if you're not going to use them, you need to think about why, and you need to think about other precautions that you might be able to put in place. And I'm sure you all might have some additional thoughts because this is a pretty ripe area right now.
There's a lot. You covered a lot there, Julie. So that was great. Eric, did you have anything you wanted to add on that?
No, not really.
Okay. Yeah, the only thing I'll just add is, and you no doubt will say this many, many times, but is just if you're really stumped on this, or if you're confused or can't find what you need, like call and consult, right? Because these things are changing, as Julie said, right? It's changing a lot. you know, none of us have ever faced this before. So don't hesitate to pick up the phone, call us and consult, talk with your colleagues. It's really important that we reach out right now. All right, so our second question is also another one, and this, we've actually gotten lots and lots of questions on this, and so we're gonna, Eric, I'm gonna direct this to you, and we're gonna take a little bit more time in going into these answers. This is about testing in particular, and I know we're sort of getting deluged with these questions. So the question here is, what guidance can you offer for a neuropsychologist regarding whether and how to return to in-person testing services for both adults and children? Eric?
Okay, well, I'm going to make 9 points briefly, if that isn't a contradiction in terms. First, because I'll only be addressing this in a limited way, I recommend that you review more in-depth presentations and information, which we have a number of links to those things in our chat box. Particularly, I would suggest you go to the Interorganizational Practice Committee of Neuropsychologists, or the IOPC. Is it .email?
.online, I think.
.online. So IOPC.online. That is a committee created by NAN in order to give people advice about doing testing both remotely and in person. So we recommend that you check that. The second important point is know your state and local government policies about reopening. Check to see whether you would be considered to be a first responder or an essential provider, which may in fact create a way for you to avoid having to do certain things that are recommended for people who aren't that. But I would recommend, from a risk management point of view, you try to adhere as closely as possible to the state rules and regulations, even if you are a provider that doesn't need to do it. Because from a risk management point of view, not following it, particularly with the kinds of services we're talking about, which probably would be considered to be voluntary or not essential, would potentially give you some problems with the licensing board where there are problems. The third point is, and this is one of the most important ones, document your rationale for your decision to proceed with testing, particularly if you would not be following your state and local government policies. The most important risk management technique that we can recommend is show your work. Document everything. It will take a longer time to do that than you would in normal situations, but particularly if you're going back in person to do neuropsychological evaluations, which take a long time, and with children, informed consent issues and everything really require you to document. So document why you believe you need to do the testing in person. Certain neuropsychological evaluations cannot be done remotely. Certain parts of neuropsych evaluations can be done remotely, and as many of them as can be done remotely should be done remotely, and you should document why you're doing what you're doing in that particular way. You also need to document theoretically your informed consent conversations, particularly if you're testing children. You want to take a look at our informed consent contract. But a contract is not really the kind of issue you want. You want to basically, essentially repeat orally for the parents most of the things that are in the informed consent contract, because they're the ones that are going to have to make the decision about whether or not to take the risk. In any situation where you're going to be doing neuropsych in person, there's going to be prolonged exposure, which many people say the 6 feet distancing is not sufficient to protect one from, particularly if you're not able to have air circulation in a particular way. So make sure you document that carefully. The safety measures that Julia suggested that you are and you are not taking. It's more important, in fact, to list the ones you're not taking and why you can't take them than the ones you are taking, because people will assume that you're following the CDC guidelines. The rationale for any substandard administration. That's another reason to go to the website we suggested, because almost everything where you do part remote and part in person is going to be substandard, and they will not have specific norms for that yet, I believe. Places you have sought guidance from, have you checked with the trust and gotten an opinion? Because a lot of these are going to be fact and case specific situations. So this overview is not going to give you all the information you need. Have you checked the NAN site? Have you checked with your colleagues who are other neuropsychologists about what they're doing? Those are things that you must, the more consultations you have, the better you will be protected against risk. Even if some of the consultations give you different opinions, that gives you in some ways more leeway, but then you have to justify the ones you're using as opposed to the ones you've rejected. The fourth important point is simple. Be aware of your own health risks. If you are an old fart like me, you want to be more careful than some of our younger colleagues here that are presenting. The fifth important point is, again, and the second most important one, is engage in proper informed consent, especially with regard to potential risks for the patients. We have, again, our suggested contract on our website. You should look at it and modify it appropriately to deal with your situation. This is not intended to be a contract that is enforceable. It's intended to be a way of giving people information about risk that's really clear and appropriate to their situation. And since there is no way you can eliminate risk, it's very important to do as much of this informed consent about risk as you can and to document that you've done it. Point 6 is make sure that the institutional system that the results are submitted to in order to receive the benefits sought will accept any NAN standard of administration. One of the reasons that it is acceptable to consider going back to doing in-person work is that parents of children may need the data and the information in your report in order to make plans for the school year next year. The other people will need you to do an evaluation so they can also access a different benefit. And you want to be sure, although it would really be the parent's responsibility or the individual's responsibility to help them know that how they can find out whether the non-standard administration you're doing will be in fact acceptable to the institution. And I've recommended to several people that have called that they may want to do that themselves because the institution would not, the parent won't be able to describe to the institution what a non-standard administration is. Point 7, remember that assessments are a single point in time and that all good assessment involves obtaining and reviewing collateral information. At this time, it becomes particularly important to obtain data on performance and behaviors prior to COVID-19 to assist you in determining possible sequelae from the current situation. For example, has isolation led to increased anxiety, confusion, etc.? I certainly know it has for me, and I can't imagine what it would be for children. Be sure, and again, in your documentation, and I can't emphasize it enough, any non-standard administration procedures and your opinion how those may have impacted test results, and that must be in your report, for sure. That if there's any possibility that it won't be reliable and valid, you must list that. The other thing to remember is if you're doing neuro, you're going to, it's a risk factor, the length of time that's required. So if you can figure out stuff to do that doesn't require in-person work, that's really an important thing to do. And also, if you're going to have to, you may not have a 10-year-old kid sit in your office for 6 hours. You may want to break that up into different visits. Even though there's more risk if you had 3 visits of 2 hours each, there's less risk that you'll get bad results in that situation. Again, this is an issue which the parents need to be involved in determining what is their level of safety is necessary. Let me just talk about risk levels for a second. Whatever number point, I've lost track. We think the chance of malpractice suits against individuals, particularly individuals in small practices, are not that high. There will be some of you that will be unlucky enough to have a lawsuit filed against you, but you should know that the trust will be there to defend you and find you a good lawyer. And it is going to be very hard for people to prove that any kind of transmission issue was caused by your allowing somebody to appear live in your office. They would almost have to have never been anywhere else in order to make that kind of proof. We think the real risk is licensing board complaints. And if you've been practicing neuropsych for a while, you know that every once in a while you get somebody who is dissatisfied with the results that you produce because they wanted a different result. And that tends to make them a little angry, and they might file a complaint, and they'll certainly, if they are a particular kind of person, throw in COVID just to make it harder to defend the complaint. So people have talked about liability waivers. We don't think they're worth the paper they are written on. It is very, my experience is that if you have a liability waiver, it will just hurt your chances rather than help you. So we don't recommend them. We do recommend that you say in your informed consent, as you'll see if you check ours, that you need to tell people that that coming to see you in person or bringing their child to see you in person is a risk. There's no way that anybody can assure them, no matter how many safety measures one invokes, that there won't be some risk of transmission. And they need to be willing to assume that risk. And if they need the data, that it's the benefit versus the risk, but you want to basically make sure they understand what the risk is. And that is a brief answer to the question. Now, all of this is individual. So if you have individual cases in different states, in different localities with different levels of COVID, please feel free to call the trust. All of your colleagues are. We've had a very big spike in calls, and we're very happy that because we think that will protect everybody. Thank you.
Yeah, well done, Eric. That was phenomenal. You got so much in such a quick time, so thanks. And I'll just comment, Julie, do you have anything you want to add to that before we?
No, that was a pretty thorough answer. I'm not sure I could add much.
Yeah, no, that was great. I was just going to comment based on some of the calls I've taken that it's important, I think, to do the informed consent like via phone or via telehealth before you're in person.
Yes.
To some people who think they should do it when they first meet with them, and of course then it's a moot point at that point, right? Because you need to talk with them about the risks of coming in.
Yeah, I agree with that completely.
Okay, great. All right, so one more question before we get to the live questions, which are coming in, so thank you for those. This last one here is, at present, I am only providing therapy via telehealth and am seeing an increase in suicidal thinking and in some cases suicide attempts by my clients. How do I manage these via telehealth? And Julie, we'll let you take this one.
Yeah, that's a great question, and it's a tough one. I mean, not only are we under the stress of the COVID-19 situation, but we have a lot of other stressors going on right now in this country, and it doesn't surprise me that people might be feeling an increase in distress and suicidal thoughts and maybe even suicide actions. The baseline that we all need to remember is the standard of care is the same, whether you're meeting someone via telehealth or you're meeting with them in person. And so we need to do all the things that we know we need to do when we're working with higher risk folks. Anytime, whether it's high risk or a lower risk client, when we're doing telehealth, one of the basic tenets and one of the first things we do as part of our informed consent process and getting this set up is to create a safety plan. And it's a little different than the safety plans we create with our high risk clients that we're seeing in person, because we need to know where the client is located and we need to know what resources there are in that location. And you need to check that at every session, because you create the safety plan on day one, but you meet them for another session and maybe they're somewhere else. And so you want to make a quick check, especially with the high risk clients. I would do it with everyone, but in particular with folks you're worried about, make sure you know where they are at the outset of your session and that you know what's going on and what the local resources are. It's going to be something that you've already created at the outset, and you're going to want to periodically update and make sure that it is current each session. You know, the contact person you identified at the intake session may have changed. That may be part of the stressor. And so you need to know what's going on, and you need to revisit that safety plan on a regular basis at each session. You need to assess for risk at every session, just like you would in an in-person situation. See if there are crisis services where the person is located. And I know that some of those services are limited right now, but there are mobile crisis units in a lot of areas, or at least walk-in crisis centers. Know beforehand whether those services are available and open and operating, so that you'll know where to refer folks if you need to in a crisis situation. And consult. And we're going to say that a lot today, but these situations, you know, between documentation and consultation, those are our biggest risk management tools a lot of times. And you want to know what other people would do in the same situation that you're in. And the best way to know that is to consult, whether that's with one of us or with your trusted colleagues, and then documenting that consultation. And to remember, this is the last point that I'm going to make for now, and I think it's one that overarches everything that we're talking about right now. Make sure that you're monitoring your own reactions and your own competence to continue to work with the folks you're working with. And if you have a client population and you suddenly have 5 or 10 people who are acute and who are experiencing suicidal thoughts or a high level of acuity, you might be feeling burnt out, and you might need to check yourself and see, make sure that you're still able to do this and you're still comfortable doing the work. And there may be situations where you may need to terminate and refer, which is easier said than done right now, right? So you might need to identify now or soon what other providers are in your area who are open for in-person services, who might be willing to take on some of these clients if it becomes a problem. Be proactive about it. Talk to your colleagues and see who's doing what right now. And so you'll know for yourself what resources there are out there. And we're helping professionals. We want to give, but there's a point where we are going to no longer be competent to do the work if we're emotionally distressed, anxious, stressed out, feeling overwhelmed. So don't forget to engage in self-care and to monitor your own reactions. And sometimes termination and referral is an option. Inpatient services are still open and running. So it may be that someone needs an inpatient setting, and that's the right thing to do. You just need to keep meeting the standard of care, make sure that you have a good safety plan, check in with your clients at every session, and check in with yourself at every session.
Great. That's lovely, Julie. Eric, anything to add?
Sure. I want to add the risk management part.
Okay.
Document, document, document. Document your thinking process, document the people you consult with, document your informed consent.
Mm-hmm.
People that end up in trouble often end up in trouble not because they did bad work, but because they have bad records.
Mm-hmm. Mm-hmm. No, that's a very, very good point. Okay, so we're going to jump into some of the live questions. And our first one here is about, looks like it's about jurisdictional telehealth pieces. So question is, are licensed psychologists and licensed social workers permitted to provide telehealth counseling to students who have left campus and are now living in another state due to COVID-19? Eric, you want to take that one?
Oh, sure, that's an easy one.
Yeah.
There's no really short way to say this because a lot of it depends on the state where the client has gone to. And most of the states have some temporary changes so that you can practice temporarily in this situation. The place to find out what the state rules are is to go to the ASPPB, that's the Association of State and Provincial Psychology Boards, that's the organization of licensing boards. They have a very good website. I don't know whether it's one of our chat box things, but you could just look them up online. They have all the temporary practice laws that are there. Now, there is some controversy about what happens in a situation where the temporary practice rules aren't allowing this to happen, but you are extending services to someone who you'd already been seeing and who needs you to extend the services. And there's a lot of case law that says that the state that the person is moved to in that situation will not be able to establish jurisdiction over you. So what you need to be, if you really think that the person needs it, then you want to have a very good justification of that you can't make an in-person referral, that you've been providing with them, particularly if they're going to come back. You don't want to assign a new therapist if they're going to come back and then see you. And we think that during this epidemic, there will not be very much risk if you do that. It's not clear whether there would be very much risk even if there wasn't a pandemic, but during the pandemic, we're pretty clear that if you were extending services, you're going to be okay. That's a very simple answer to a very complicated legal question.
Yeah, but I think you hit the highlights there, Eric. And for those of you listening, we have addressed some more of those details in some of the prior webinars as well. So you can look at some of that. I think one thing I'll add, and then Julie, I'd be interested to hear if you have anything to add too, is that it gets a little complicated depending on how long the student may be away, right? I mean, if it's temporary over the summer and they're coming back in August for the fall semester, I agree, Eric, that I think there's a lot of, you know, with the waivers and various things like that make it pretty easy, especially if you're continuing care. If a student is going to be away until 2021, right? If they're not going to come back till January or February of next year, you may want to think about that. It may be that at some point you need to think about transferring them rather than waiting that long. We don't know what the temporary waivers are going to do, but just something to sort of put on your radar screen, I think, to be thinking about. Julie, anything you want to add?
Yeah, just to echo that, I think it's a good idea to, you know, maybe set timelines for yourself. You'll check in every month and see if there's been a change in the situation, if it looks like they may be staying longer, just to have some way to make sure this doesn't go on forever, because these practice provisions are temporary. That's why they are called temporary. So the intent is not for you to be able to practice into another state for long-term therapy basis. If they're going to be gone for months and months, and you don't believe they're going to be coming back in fall, you might want to think about that termination and transfer process. The other thing I'm going to say really quickly, because it's just I think I heard in that question, both psychologists and LCSWs were mentioned in that question. The temporary practice provisions and the licensure exemptions may be different for social workers and for psychologists. So the ASPPB website is great for psychologists. It is not going to cover necessarily the social work laws. Now, some of them apply broadly to all mental health professions, but be sure that if you are an LCSW or you're looking for a different kind of licensee, that you don't just presume that the psychology laws are going to follow and going to apply to all licensees.
Lisa, can I add one thing too?
Yeah, please.
Remember that if these people were seen in college counseling centers and you're extending those services, they were never intended to be provided long-term services anyway. College counseling centers usually do 10 sessions and have to get a private therapist if that still need for services. So in that situation, it is appropriate to be transitioning them to somebody private.
Mm-hmm. Right, perfect, thank you. And that's a great point, Julie, about the social worker laws too, so perfect. Okay, next question. A client told me at the start of the session that he is camping. I did not have an emergency plan. Is it okay to continue? So I think there's a bunch of pieces there. The question is not entirely clear, but Eric, do you want to do that since it's about—
What was he doing? He was doing what? I didn't hear.
Camping. So the patient went camping. I think part of it is about if the patient is in a place where you don't expect them to be. I'm not sure about the piece of the emergency plan because I don't know if there was an emergency or not. Can you explain a little bit about what do we do if it turns out that our clients are someplace we don't think they were, like we didn't?
I would say that if they're in a place where that you wouldn't do, that it's an inappropriate place to do therapy in, that you would say no.
Mm-hmm.
I certainly wouldn't want you to do therapy with somebody in a Starbucks. Camping, I think, is a complicated question because is much, depending on where they're camping, there may be a lot of privacy or there may not be any. I've camped in sites where there's nobody there, and I've camped in sites where there are RVs right next door. So that would be important. One of the things I would say is that when you do, online treatment, you want to make sure of where they are, and you might even want them to scan the area to make sure it's appropriate.
Yeah, and I agree, Eric. I also think we can help this a little bit with our clients by sort of educating them that we want them to tell us, hey, if you're going to be camping next week, let me know so we can talk about that, that kind of thing. So helping to get them on board with letting us know is I think, something too. And
one more thing, you might want to just say, I'm not going to do a whole session with you, but if you want to check in, I'll do 5 or 10 minutes. And I either won't charge you or I will charge you, but I don't want to do a whole session while you're camping because I don't feel comfortable with that environment for doing therapy.
Yeah, that's
well, and I feel compelled to jump in here as an avid camper. Because you alluded to this, Eric. There's a lot of different types of camping, right? I mean, clearly if someone's able to connect with you on a video conferencing platform, they're not too far out off the grid and in the middle of nowhere, or one might presume. If they're in a campground in a fairly populated area, I mean, we've got a couple campgrounds right outside where I live. People could be in a camper hooked up with electricity and around resources. It's not that different than being home. So I do think it's actually to some extent on a case-by-case basis. If they're out in a tent alone in the woods, I understand the concern about safety planning, right? And I think that might be what they were alluding to, is how do I have a crisis plan if there's no way for this person to get anywhere and they have to get in their car, break down camp and drive somewhere for 4 hours. Okay, that's a concern. And that would be a difficult session to hold. And I think, Eric, that would be a time to maybe do a check-in and let's schedule something for when you're home or somewhere closer to civilization. But if they're camping in a campground and there's lots of resources around and they're able to tell you where they are and you're able to identify resources in their area, it might be okay to proceed. So it's going to depend a little bit on your comfort level and where they are, who they are, lots of individual factors. And I understand that it's going to be tricky if you hop on the phone or you hop on the call and there they are and you didn't have time to plan. So it's something you want to think about a little bit and be ready to ask those questions and think on the fly and decide which direction you want to go, whether to hold that session or not.
Mm-hmm. Yeah, and I think we're hearing a lot sort of this idea of we need to be flexible, we have to take things on a case-by-case basis, and then of course we have to use our good clinical judgment, right? And then as Eric said, we need to document. Just document what do we do and why. So, okay, this looks like a question related to what you were talking about earlier, Julie. The question here is, do so-called UV-alizer, quote-unquote, lights or fans help? Dyson fans with HEPA filters, those kinds of things. I think that's getting to the question of air ventilation. Do you want to address that?
Yeah, I mean, I'm not up on the science, I'll be honest, but I would encourage people to research those things. If you see something, a fan or something that is a air filter or something that looks like it might be useful, Google it. Look at what's out there. Look at the specifications. See what you can find out in terms of effectiveness. Room size is going to impact that. I mean, there's a lot of different factors to consider, but I do think it's incumbent on us to do a little bit of research. You're not going to just buy the cheapest thing that you can get first and assume that it's going to work for you. You want to take a look at some of the specifics. Now, I don't know a lot about the UV radiation or things like that. It's just something, it's outside of my scope. So I would be consulting with someone who does know those things. And I would be asking a professional in that area, what do you know about these objects, or I'm sorry, these strategies for, sanitizing and freshening air and filtering air, and find out from the experts. And it's a really good example. None of us has all the answers. That's why, I'm happy to consult with someone who knows something I don't know. And I think that's a perfect situation to spend a couple hours and do that digging and see what's out there and what's deemed to be most effective.
Great. Excellent. And then because this is very quick, someone says, has anyone seen a clear mask, meaning not a face shield, but a mask? And the answer is yes. As Julie said, they do have some masks that are see-through. Folks who are hearing impaired use them so they can read lips, things like that. So, Google it, see what you can find, but they are out there for sure.
Can I just say something too? Be really careful about this, because there's a lot of people that are trying to take advantage of trying to make money. And if it's too good to be true, it probably isn't true.
Yeah.
You're not going to get something that's really effective for $19.99.
Right.
Yep.
All right, so this is actually something not related to COVID, but I know it's on the hearts and minds of a lot of folks. The question here is, please share thoughts about the current emotional climate around the George Floyd issue and suggestions about how to help clients. Eric, do you want to start us on this? Maybe I'll jump in. But.
Well, we have some very important self-care information on our website, and I would encourage you to look there. But I have to say, I really don't know what to tell people about this, because I was feeling pretty sanguine myself until all the all these riots started, and not riots, I mean protests, whatever you want to call them. One of them took place a block away from my son's house in LA. And that was incredibly upsetting. And I fortunately managed to deal with it. But there's a lot of things that are going on now, and I suspect they're going to get worse before they get better. And so you just have to use your best, you have to be able to try and heal yourself as best you can. Meditation stuff is really important. Being able to get out and take a walk is really important. Keeping in touch with your loved ones and other colleagues about what they're doing. And also, if colleagues are calling you and you feel like they're not behaving, that they really are at risk, tell them, don't protect them. but it's very hard to know. And by the way, this is a question we get at the trust, and it's a perfectly appropriate one to call and ask for a consult with one of our risk management consultants who know about this.
Yeah, excellent. Julie, anything to add?
Yeah, I mean, these were already incredibly difficult times, and they seem to be getting harder and not easier. Self-care is key. For me, and I won't get into a lot of detail, excuse me, a way that I've had to cope over the past few days is to figure out how I can align myself with what's going on, and I can feel good about taking some sort of action and making sure that people know what my position is. So if you feel like you need to take some action, or if you need to educate yourself about what's going on out there and be a part of this, be a part of it. Listen to people, listen to people who you trust, who can talk to you about ways to help and contribute. Take good care of yourself. Listen to your clients. Honor and validate what everyone is going through. We're going through multiple crises right now, and all of us are going through them together on some level. We're all experiencing this together, and it's really interesting to sort of watch ourselves from a 10,000-foot view and see us reacting to the same thing that our clients are reacting to. And so it's a time to really connect as best you can with the people who can help you, and help your clients connect with people, and hang in there. This is, like Eric said, it's not going to get better quickly. We're in for a marathon here, folks, on a lot of different levels. And we all need to make sure that we're taking care of ourselves, and we're taking action that we feel is appropriate, that aligns with our values, and that moves us forward during these times.
Yeah, and I think, we all know, right, that there's a tremendous amount of fear and anger and hurt, and sort of being whipped up almost more and more. And I think both for ourselves, right, bringing compassion when we think about ourselves and what we're managing, but also, of course, bringing that to our clients. The question here in part is about how do we help our clients with that? Well, I think helping our clients, helping ourselves is helping our clients, but we can do for them what we would do for ourselves, right? Compassionate listening, allowing them, as we always do, right, that space to talk about how are they experiencing this, right? What is their reaction? Are they feeling scared? Are they feeling angry? How does it impact them, right? Because it's going to impact everyone slightly differently, right? And some of our clients may feel it very personally, some may not, but I think just being as present and available as we can to wherever they are. Of course, there are resources, I think, at APA. There's various places that have resources about the science of sort of, what does our research say about responding to some of these things? And I think it's good for us to know that. And then I think just being present, and also sometimes voicing the common humanity, frankly, right? Like, we, all of us have, I think, different registers for how much we share about ourselves, right? But I think in situations like this, it is oftentimes okay to say, yeah, we're all affected. Like Julie said, none of us are outside of this, right? We are all impacted by this. And sometimes just letting our clients know that can be helpful.
I would add that this is a time where you particularly need to be somewhat thoughtful about boundaries.
Yeah.
Because when you want to share your feelings in order to help you connect to your client and what they're feeling, there's a real danger of talking about your own feelings more than is not burdening your client with you. They're not there to be for you to share your problems with them. So it's a difficult dance.
Yeah, no, Eric, I completely agree. Certainly wasn't suggesting that. So we need to, and that's, I think, getting back to what all of us are saying about that self-care piece. We need to know what our stuff is, and we need to tend to our stuff separately, right? Really tend to it. But I think it is okay in some instances to say, like, yeah, we're all feeling this. This is really, we wake up in the morning and hear this terrible stuff. Like you say, your son is right down the block. It's terrifying. And so some of that connecting, I think, is good. But I think, I do agree with the boundary issues and that guidance. And then I think too, listening is really the key, right? It's listening, whether there's persons of color or whoever, I think listening, we just need to listen. We need to be less reactive. The whole country maybe needs to be reactionary and what's really going on. Any other comments there before we move on?
No.
All right, next question. Would you include clients waiting in the car rather than office waiting room with the call upon arrival? I think this is getting at sort of some of the safety precautions. So in other words, would you tell your clients to wait in the car rather than waiting in the wait? Julie, you want to take that just because you were on
Yes, yes, and yes. I think anything that you can do to decrease the amount of time that people, or the level of potential exposure people have, is a good idea. And not everyone drives to a session, right? So you might want to just say, wait outside, wait outside the building, and you can offer to text or call or email them when they're ready, when folks are ready to come in and actually see the next patient. I think that's something that a lot of people are doing. It's not necessary, absolutely. If you only have one person scheduled and then the next person is scheduled 4 hours later, okay, they may be able to come into your waiting room if you have a single-use waiting room and you know there aren't going to be other people there. So it depends a little bit on the space that you're using, but if it's a shared space and there's potential for people to be sitting in a waiting room and being exposed to one another, you can reduce that exposure by asking them to wait elsewhere and to not have people sitting in that waiting room for an amount of time.
Okay, great.
One more thing.
Yep, go ahead, Eric.
A lot of people, instead of having people wait in the car, are timing things, telling people to come 5 minutes before their appointment and then sit in the waiting room. And if you control your waiting room,
right?
As people said, if they're sharing it, you can't do that. But
Okay, great. So here's another question. This person says, in being credentialed to be a provider on an insurance panel, the insurance is requiring that I have, as a sole practitioner, a written document covering the federal and state regulations for providing telehealth. This sounds like an extensive document. What do you recommend covered to address these laws and regulations in such a document? Eric, do you want to start with that?
I have to say, I haven't a clue. Even I, who am supposed to be keeping up with this stuff, would have a hard time creating such a document, and I would have to change it every 2 or 3 days. I don't know what to say. This seems to me to be a sentinel effect for the insurance company, that it's trying to discourage teletherapy. I would just basically say, go to our website and get as much information as you can. What do they want you to do with the statement? Give it to each client? I don't.
Yeah, that's kind of what I was thinking, is maybe go back to the insurance company and understand a little bit more about what is the purpose of this? Is this something that's for you, insurance company, to know that I am following the laws? Or is this something like Eric is suggesting, is this to go to the clients? So understand a little more about the purpose of the document and what they actually need. I mean, I can create something that links to my state laws pretty easily. Even if they change, it'll just be a link. So it's an unusual thing. And, I'm like Eric, I'm not really sure. It's not a question I've come across. It's not a requirement I've heard before. So I would want to know more about the actual specifics of the requirement, and then we could sort of try to help guide and figure out what would need to be a part of a document like that.
One other thing I would say about that is that if you are a member of your state association, they will have heard of this, and they will be in a much better position to take action with the insurance commissioner or whoever they can do it politically, because this really strikes me as a kind of requirement that's kind of a gotcha requirement.
Yeah.
If you go to the insurance commissioner, it's probably not going to be very effective. But if your state association goes to the insurance commissioner, at least where I am in Massachusetts, that's been a very effective way of dealing with insurance companies' attempt to not pay for what they should be paying for.
Okay, great. And this is sort of in reference to what we talked about earlier on the informed consent, but the question says, if I do the consent to treat via telehealth prior to actually seeing the patient in person, can I bill for this time spent? Who wants to do? If you're in essence going to do like a telehealth session almost to go through the informed consent process in advance, can you bill for that?
That's an interesting question. Can you? Maybe. Should you? Probably not. You won't have signed a contract with the person yet. They won't actually even know your fee structure yet. You won't have gone through the informed consent with them yet. They might be a little put off that you expect them to pay for an introductory kind of session. If you're going to do that, I would certainly let them know as you're setting up that session that you expect them to pay for that time. That it might be more of a business decision and a risk management decision in the sense of, do you want to make someone angry before you even start working with them, or do you want to set up an expectation where they have a little bit of a bad taste in their mouth because you're charging them to fill out paperwork with them? I mean, so sometimes can and should are different questions, and I suspect potentially you can. I suspect potentially you may not always want to do that, and it may not be the best decision. Now, if you're spending hours doing this, then you might need to rethink your model of how you're doing it, because you certainly shouldn't be spending a huge amount of time without being compensated.
Mm-hmm.
Also, you should never, this would be insurance fraud if you billed insurance companies for it. It is not you.
Yes, billing insurance, sorry, I didn't key on that. Charging out of pocket would be one thing. Billing insurance would not be appropriate.
Yeah, and keep in mind too, I mean, I think, I know we obviously want to be compensated for our time, but, most offices, doctors' offices, vets' offices, dentist offices, they are going through these things in advance, but they're not charging for that. So just be aware of what's also happening in your area with other businesses, because that may set you apart either in a good way or a bad way, like to get at what Julie was saying. So, okay. Can you talk a little bit about disinfecting testing materials between clients if we decide it is necessary to provide face-to-face testing? Anything? I mean, this might just be that we need to refer folks back to,
it depends on how long it's going to be before somebody else touches them. If you're doing them every day, then yes, absolutely. You can do that. If you're doing it once a week, the virus won't last that long. So that is important to know what is and isn't something that's likely to spread. But you can never go wrong by disinfecting things. That's the safe thing to do.
And the CDC website does actually have specific guidance on disinfectants to use and processes for disinfecting and sanitizing things. So if you go to the CDC website, you can actually find some really specific, that's something they were specific about. Maybe not about how often you should do it, but what you should use and what kind of products will be effective. You can find that information on the CDC website.
Right, perfect. Okay, how long do you recommend keeping, quote, good record keeping, documentation, files, and consultation records? This is an easy one, Eric. Do you want to address that?
That is a state-by-state question. APA recommends 7 years from the last date of service, or somebody's, I think 19th, or is it the 21st birthday? I get confused sometimes.
18th.
Which is longer.
Mm-hmm.
But states have different rules, and California, for example, requires you to have it for 7 years. And if it's a minor, it has to be 7 years from the time they become an adult. So you really have to check your own. Massachusetts is 5 years, but 7 years is a safe amount of time, and you need to keep all the every bit of documentation should be kept.
Yep, and that's just the kind of question we can answer for you. If you have a specific question about your state and you're not able to find it easily, you can call us and we can look that up for you. But 7 years does seem to be the most common time frame. And I just want to echo what Eric said. Everything should be in the record. I think I get questions sometimes about, should I put email communications in the record? Should I put text communications in the record? I say yes. Put everything in the record. It's didn't happen if you don't have it documented, and you want to be able to show your communications with clients even if they're not all clinical. I wasn't exactly the question, but I just had to toss that in there.
One more thing, Medicare is 10 years. So if you're seeing Medicare clients, you have to keep those 10 years.
Great. So thanks. I missed part of that because I got kicked off because of an internet issue here, but I'm back. Okay, moving to another question about college counseling service question. If the student is in another state where you are not licensed, can you one session or 2-session crisis support to assess for risk and then connect them with local care? Also, can they attend a one-time assistance if
We're losing you, Liesl.
We lost you a little bit there, Liesl. But I think it sounds like the question is sort of about doing crisis care and shorter term 1 or 2 sessions with someone who's a college student who's gone home and needs services. I'm going to answer it as if that's the question. I see you nodding, so I think I got it. Yeah, I mean, you want to think about, when you're thinking about interjurisdictional practice, there is the legal piece, right? There is the temporary practice provision, there's the requirement for licensure, there's needing to practice legally. But you also need to think about ethical and clinical considerations. And if you have an ongoing client and they have gone home and they haven't connected to a new provider yet, and they're in crisis and they call you up, do something. Your licensing board is going to look less favorably on you for saying, sorry, I can't talk to you, I'm not licensed in your state, than for potentially not being licensed, practicing without a license, but providing ethical and appropriate care to someone who needs it. We can't abandon our clients. And so if you're going to do this and you're doing it in a way that you haven't been able to find a temporary practice provision and you're not licensed in the state, document very clearly what you are doing and why. And your recognition that I am not licensed in Ohio, but my current client who has gone home temporarily is in Ohio and is in crisis. And rather than abandon them and cause harm and potentially have them harm themselves, I am going to provide these services with the understanding that it is not perfect, but it is in service of my client. And so documentation becomes very important in those situations. I think the odds of a licensing board taking action against someone for doing short-term temporary services for someone who is a current patient and is either transitioning to care or has left the state temporarily, the odds are very low that you're going to face serious sanctions for that. I think the odds would be much higher of facing sanctions for just abandoning someone because you decided you weren't going to take the risk of talking to someone for an hour or two because you're not licensed in their state. I'm not saying just go out there and have a good time and practice in every state all the time, but clinical considerations and ethical considerations are going to trump the legal considerations in a lot of situations. And the important thing is you explain why in your documentation so that 2 years from now, if something goes wrong and the licensing board needs to understand what you did and why you did it, you don't have to try to create that and remember it. It's going to be documented at the same time that you did it. It's going to be excellent evidence of you being an ethical and thoughtful provider.
To take a legal position, there's one of the cases that's really important in this area that basically says it's not good policy if a doctor has to only be able to give someone enough aspirin to get them to the next jurisdiction. That you have to be able to treat the client and the client's needs. The services aren't directed to the location of the client, they're directed to the client themselves. And if the client really needs them, you should provide them.
Yeah.
Within reason.
Terrific. So the last one, because we have just like 2 minutes, so we're going to try to sneak this in real quick. I know it's actually being asked multiple times, and you may not have a specific answer to this, but what about the issue that at some point the insurance companies here may, and they have been threatening, I think, in various states, to change back to the pre-COVID reimbursement for telehealth sessions? How can providers sort of, how can they know when that's going to happen, and how can they address that with their clients? Julie, do you want to start on that?
Yeah, I'll jump in real quickly with that one. State associations are your friend here. My state association in Colorado, we introduced a bill yesterday to permanently codify the changes that were made for teletherapy reimbursement, and it made it through the first committee today. And so if you've got changes that were made in your state that were good, talk to your state association about trying to make those permanent. Otherwise, you have to keep an eye on the executive orders and waivers that are in place in your state. And again, your state association may be a really good place that's gathering that information and may be able to give you some guidance on that.
Yeah.
There's little that you can do as an individual to affect this kind of policy by yourself. You just have to try and keep in touch with it. Only a state association or some organized body of people can actually deal with these people on a level that they have respect for.
Yeah. And it does work. It works.
And those are great ideas. I also just add, in terms of your clients, I think it's important just to be transparent with them that we don't know. We don't know when they change this, that it really may affect what is being reimbursed or not, and that you will let them know as quickly as you know, and that you guys can continue to make decisions about that together once you do know what that situation is. But I think being upfront with our clients about that is really important.
Definitely.